Hey ladies, welcome to GOC Grace channel. It's time to explore about your urinary bladder as one of your body organs. In just a few minutes per day, you can take control of your health and well-being. Always remember that you should not try to take care of your health on your own. Consult with a doctor for advice. Today, we will look at bladder pain syndrome, also known as interstitial cystitis. Bladder pain syndrome (BPS), also known as interstitial cystitis (IC), is a chronic condition characterized by persistent pain, pressure, or discomfort perceived to be related to the urinary bladder, often accompanied by urinary frequency and urgency. BPS or IC is a poorly understood disorder, often debilitating, with significant impacts on quality of life, and poses diagnostic and therapeutic challenges. Terminology and classification: bladder pain syndrome and interstitial cystitis are often used interchangeably, though subtle distinctions exist. Interstitial cystitis (IC) traditionally refers to a condition marked by bladder inflammation and histological evidence of Hunner's lesions ulcers. Bladder pain syndrome (BPS), a broader term endorsed by the European Society for the Study of Interstitial Cystitis (ESIC), encompassing cases with bladder-related pain without an identifiable cause. ESIC classifies BPS based on cystoscopic findings and biopsy results, for example, with or without Hunner lesions, presence of inflammatory cells, etc., allowing for a more nuanced approach to diagnosis and management. Epidemiology, prevalence. BPS or IC affects millions globally, with varying prevalence rates due to differing diagnostic criteria. In the US, estimates suggest up to 8 million women and 4 million men may experience symptoms. Gender: women are disproportionately affected, about 90% of cases, though awareness is increasing in men. Age: most commonly diagnosed in individuals aged 30 to 50 years, though it can occur at any age. Etiology and pathophysiology: the precise cause of BPS or IC remains elusive, but several hypotheses exist. Urothelial dysfunction: damage to the bladder's glycosaminoglycan (GAG) layer allows irritants in the urine to penetrate and inflame underlying tissues. Neurogenic inflammation: altered sensory nerve activity and upregulation of pain pathways in the central nervous system. Autoimmune mechanisms: similarities with other autoimmune diseases suggest immune dysregulation may play a role. Mast cell activation: increased mast cell infiltration in bladder tissue, contributing to inflammation and pain. Infection and post-infectious changes: though no consistent pathogen is identified, some cases may be post-infectious. Psychological factors: higher rates of anxiety, depression, and stress disorders are reported, possibly exacerbating symptoms. Comorbidities: often overlaps with conditions like fibromyalgia, irritable bowel syndrome, and chronic fatigue syndrome. Clinical feature: cardinal symptoms: bladder-centric pain, burning, pressure, or aching that worsens with bladder filling and improves after voiding. Urinary urgency: compelling need to urinate, not necessarily linked to incontinence. Frequency: urinating more than 8 times a day, often small amounts. Nocturia: waking at night to urinate. Other symptoms: pain during sexual intercourse, dyspareunia, pelvic or perineal pain, suprapubic discomfort. Fluctuation in symptoms, often triggered by diet, stress, menstruation. Diagnosis: BPS-IC is a diagnosis of exclusion. Key steps include history and physical exam, detailed urinary and pain history, pelvic exam in women, prostate and pelvic exam in men. Diagnostic tests: urinalysis and urine culture. To rule out infection, cystoscopy may reveal Hunner lesions or glomerations, especially post-hydrodistension. Bladder diary tracks voiding frequency and volumes, Potassium sensitivity test (PST). Historically used but not widely recommended due to low specificity. Basic diagnostic criteria: chronic pelvic pain 6 months, one or more urinary symptoms, urgency, frequency, exclusion of other identifiable causes, for example, UTI, bladder cancer. Differential diagnosis: BPSIC symptoms overlap with various conditions, urinary tract infections (UTIs), overactive bladder or bladder cancer, endometriosis, chronic prostatitis, or chronic pelvic pain syndrome (CPCPS), gynecologic disorders, for example, vulvodynia. Treatment and management. Management is tailored and multimodal, progressing from conservative to more invasive interventions. Behavioral and lifestyle modifications: bladder training and timed voiding, fluid management, stress reduction and cognitive behavioral therapy, dietary modifications, avoid caffeine, alcohol, acidic or spicy foods. Physical therapy, pelvic floor physical therapy, to address myofascial pain or dysfunction. Oral medications, amitriptyline, for pain and urgency, with sedative effects. Pentosan polysulfate sodium elmeron, the only FDA-approved oral drug for IC, replenishes gag layer, antihistamines. Hydroxyne may help if mast cell activation is suspected. Analgesics and NSAIDs, for pain control. Gabapentinoids, pregabalin or gabapentin, for neuropathic pain. Intravesical therapy, direct bladder instillation of agents, for example, lidocaine, heparin, DMSO to reduce inflammation. Advanced therapies, hydrodistension, bladder stretching, under anesthesia can provide temporary relief. Neuromodulation, sacral nerve stimulation for refractory symptoms. Botulinum toxin, a Botox, intravesical injections to reduce urgency and pain. Surgery, reserved for severe refractory cases. Options include cystectomy, bladder augmentation, or urinary diversion. Rare. Prognosis and quality of life. BPSIC is a chronic, fluctuating condition. While not life-threatening, its impact on physical and emotional health can be profound. Many patients experience a reduced quality of life due to sleep disturbances, sexual dysfunction, emotional distress, work and social limitations. Long-term prognosis varies. Some achieve symptom control with treatment, while others struggle with persistent symptoms. Research and future directions. Emerging areas of interest include identification of reliable biomarkers, genetic predisposition studies, new pharmacologic agents targeting inflammation and neural pathways, use of regenerative medicine, for example, stem cells, platelet-rich plasma. Ongoing clinical trials aim to better define subtypes of BPS or IC and personalized treatment strategies. Conclusion: bladder pain syndrome or interstitial cystitis is a complex and multifactorial condition that necessitates a holistic and individualized approach to care. Advances in research are progressively unraveling its pathophysiology, with hopes for more targeted and effective therapies in the future. Patient education, empathy, and long-term support are key elements in managing this challenging disorder. Always remember to ask for help and support when you're struggling with any health condition. If you need additional information, don't hesitate to ask. See you on our next post.